Hello, my name is Rashida Shah and my presentation is on asthma, and this is for the class Neuro 674. First, an asthma overview. Asthma is a chronic disorder with airway obstruction, bronchial hyperresponsiveness, and airway inflammation. The percentage of adults with asthma are 8.4%, and percentage of children with asthma are more than 5.8%. The annual number of office visits for asthma are 5.8 million, and the number of emergency department visits with asthma as a primary diagnosis is 1.6 million. There has been increased mortality rates with asthma in elder adults and African Americans. The risk factors or causes of asthma include genetic predisposition, family history, allergies, antenatal exposure to tobacco smoke. And asthma severity is impacted by age of onset, pollution exposure, presence of GERD, and respiratory infections. An individual with asthma can have a wide range of signs and symptoms. These include episodic wheezing, chest tightness, immobilizing attack, breathlessness, coughing at night or early morning. Asthma attacks are usually due to bronchospasm, edema of bronchial mucosa, and mucus plugging. Expiration is prolonged due to progressive airway obstruction. Mild asthma attacks include chest tightness, increase in respiratory rate, prolonged expiration, and mild wheezing with cough. Severe asthma attacks include use of accessory muscles, air trapping, which causes distant breath sounds, and loud wheezing. Worsening conditions usually are indicated by fatigue, moist skin, anxiety, and apprehension. There's severe shortness of breath, and the patient is only able to say one or two words between breaths. Respiratory failure includes airflow, decreased breath sounds, inaudible, and diminished wheezing. The cough is ineffective. Asthma has an effect on the bronchioles. The airway of the lungs are made out of cartilaginous bronchi, membranous bronchi, and gas-exchanging bronchi, termed the respiratory bronchioles and alveolar ducts. During an asthma attack, smooth muscles located in the bronchioles of the lung constrict and decrease the flow of air in the airways. The amount of airflow can further be decreased by inflammation or excess mucus production. Okay, so the pathophysiology of asthma on a macroscopic level involves, as I mentioned in the last slide, involves bronchial inflammation with airway constriction and resistance that manifests as episodes of coughing, shortness of breath, and wheezing. It can affect the trachea, bronchi, and bronchioles. There are defined sharp contractions of bronchial smooth muscles. Bronchospasm causes the airways to narrow, and edema from the microvascular leakage contributes to airway narrowing. Airway capillaries may dilate and leak, increasing secretions, which in turn causes edema and impairs mucus clearance. Asthma also may lead to an increase in mucus-secreting cells with expansion of mucus-secreting glands. Increased mucus secretion can cause thick mucus plugs that block the airway. Injury to the epithelium may cause epithelial peeling, which may result in extreme airway impairment. Loss of the epithelium barrier function allows allergens to penetrate, causing the airways to become hyperresponsive, a major feature of asthma. The degree of hyperresponsiveness depends largely on the extent of inflammation and the individual's immunological response. Asthma also causes loss of enzymes that normally break down inflammatory mediators, with ensuing reflexive neural effects from sensory nerve exposure. With proper treatment and control, asthma may cause airway remodeling, leading to changes to cell and tissue in the lower respiratory tract. These changes cause permanent fibrotic damage, such remodeling may be irreversible, resulting in progressive loss of lung function and decreased response to therapy. So asthma pathophysiology on a microscopic or cellular level involves IgE, which is an antibody that targets antigens such as bacteria, viruses, or foreign items in the body. On exposure to a trigger, excessive release of IgE occurs, which initiates B lymphocyte activation. IgE binds to cells related to inflammation. This activation causes the release of inflammatory mediators such as chemokines, nitric oxide, prostaglandin, D2, cytokines, histamine, and leukotrienes, in turn triggering airway inflammation and bronchoconstriction. Women who smoke during pregnancy may predispose their unborn child to higher IgE or antibody levels, causing hyperresponsiveness and asthma development. Exposure to pollution may also have the same effect. Non-atopic asthma doesn't involve an IgE response. It may have fewer obvious triggers and usually occurs in adults. This is possibly a secondary reaction to a viral infection. As I mentioned in the previous slide, cells and proteins are important components in causing an inflammatory response to triggers. So T2H helper cells develop from CD4 plus lymphocytes and respond to allergens and parasites by stimulating B cells to differentiate to IgE producing plasma cells. They recruit and activate eosinophils, which are white blood cells, and people with allergic asthma have pro-inflammatory T2H response. Cytokines are mediators, as I mentioned in the previous slide, and they're proteins that control growth and activity of blood and immune cells. Tumor necrosis factor cytokine is released from mast cells and causes airway inflammation. It causes increased migration and activation of inflammatory cells, and it can also cause airway remodeling, which is done through activation of fibroblasts. There are two phases of asthma exacerbation, an early phase and a late phase. As mentioned before, a trigger from the environment causes the release of IgE antibodies that are synthesized and released by plasma cells. IgE antibodies then bind to high-affinity mast cells and basophils. When a pollutant or risk factor gets inhaled, the mast cells release cytokines, which are protein mediators, as mentioned before, including histamine, prostaglandins, and leukotrienes. This causes a contraction of the smooth muscle and causes airway tightening. Th2 lymphocytes also play an integral role where they produce a series of interleukins which aid in communication with other cells and sustain inflammation. During the late phase of asthma exacerbation, eosinophils, basophils, or neutrophils, which are white cells, and helper and memory T cells all localize to the lungs as well, which perform bronchoconstriction and cause inflammation. Mast cells also play an essential role in bringing the late phase reactants to the inflamed site. It is critical to recognize both of these two mechanisms to target therapy and relieve both bronchoconstriction and inflammation depending on the severity of the disease. Interestingly, those with a thicker airway over time have a longer disease duration due to a narrower airway. Asthma's effect on the body system. An individual diagnosed with asthma has double the risk of a cardiovascular event like a heart attack, stroke, or related condition, and taking daily medication for asthma can increase the risk of a cardiovascular event by 60% over 10 years. It also, an individual with asthma has a greater frequency of gastrointestinal symptoms, including diarrhea, vomiting, and abdominal pain. An individual with asthma who is taking medication has a disruption in the homeostatic balance maintained by this part of the excretory system. Too much carbon dioxide builds up in the blood, causing fatigue, shortness of breath, confusion, headache, and metabolic acidosis. Clinical practice guidelines from the U.S. Department of Human and Health Services and NIH include information about the diagnosis, treatment, and management of asthma. For the diagnosis, there is a need for careful history, physical exam, laboratory findings, and diagnostic testing. Diagnostic testing include a chest x-ray, which is useful in ruling out a differential diagnosis such as an infection. Spirometry is the gold standard for asthma diagnosis. This is used for patients of 5 years of age or older. You have to obtain a baseline using spirometry, and then the patient is given a short-acting beta agonist, usually albuterol, 2 to 4 puffs of 90 mcg per puff, and then recheck the spirometry in 10 to 15 minutes. If there's an increase of FEV1 greater than 200 milliliters and 12% from baseline, this confirms the diagnosis. FEV1 is the amount of air a person can force out in 1 second. A peak flow meter is also used it's usually used for monitoring asthma and the risk for exasperation. It measures how hard a patient can breathe out, and low peak flow readings mean asthma is getting worse. Clinical practice guideline treatment. In order to determine which treatment the provider must give to the patient diagnosed with asthma, the provider must look at the stage that the patient is in. There are 4 stages of asthma, including intermittent, mild persistent, moderate persistent, and severe persistent. Treatment includes prevention measures, non-pharmacological measures, and pharmacological management. Prevention measures include limiting exposure to irritants and having the annual influenza vaccine. Non-pharmacological measures include relaxation techniques, control breathing, and allergen immunotherapy. So as mentioned in the last slide, there are 4 stages of asthma, and based on the stages, the treatment is decided. So for mild intermittent, this is usually when a patient has asthma exacerbation of less than 2 days per week and less than 2 nights per month. And the PEF, which is the peak expiratory flow, which is the amount of air that can be exhaled, maximum flow of air that can be exhaled, is greater than 80%. Usually for this patient, only the short-acting beta agonist is used. For mild persistent, which is having an asthma exacerbation greater than 2 times per week and greater than 2 nights per month, which usually requires a low-dose inhaled corticosteroid. Moderate persistent is when there's a daily attack affecting activities greater than 1 night per week, 60 to 80% peak expiratory flow, and this one usually requires a low to medium dose inhaled corticosteroid plus a long-acting beta agonist. For severe persistent stage of asthma, this means that it's continuous and there's limited physical activity, but there's still asthma exacerbation, and usually it's frequent at night too. And the peak PEF is less than 60%. A high-dose inhaled corticosteroid plus a long-acting beta agonist is used, along with an oral anti-inflammatory if needed and oral glucocorticoid as needed. Evidence-based guidelines for pharmacological treatments differ from patients from 0 to 4 years of age and then 5 years and greater. The goal is to maintain a long-term control of asthma with the least amount of medication. Also, to reduce impairment, prevent troublesome symptoms, and have infrequent need for SABA, and reduce risk, which means prevent asthma exacerbation and the need for ED visits. A long-term therapy to reduce impairment and risk is considered if required symptomatic treatments more than 2 days per week for a period of more than 4 weeks, and ICS is the inhaled corticosteroids is the preferred therapy for initiating long-term control therapy in children of all ages. For the first year of treatment, 1 centimeter is used, and then budesonide nebulizer solution is approved for children of 1 to 8 years of age. Evidence-based pharmacological treatment for patients diagnosed with asthma from the ages of 0 to 4 years. For intermittent asthma, SABA or short-acting beta agonist or albuterol is taken as needed to treat symptoms and is usually sufficient therapy for intermittent asthma. It is taken every 4 to 6 hours as needed for 24 hours and longer with a physician consult. For persistent asthma, it requires symptomatic treatment of greater than 2 days a week or for greater than 4 weeks. SABA should be taken as needed to relieve symptoms, and a course of oral systematic corticosteroid may be necessary. This is a chart indicating the asthma treatment for 0 to 4 years of age. Step 1, as I mentioned before, you use the short-acting beta agonist, PRN, and then step 2 to step 6 is for persistent asthma. Step 2 is for you use the low-dose inhaled corticosteroid, and then for step 3, medium-dose inhaled corticosteroid, and then step 4 is also medium dose inhaled corticosteroid with a LABA or a long-acting beta agonist. And then step 5 and 6, which is severe persistent asthma management, has high dose inhaled corticosteroid and a LABA long-acting beta agonist. Evidence-based guideline for management of asthma for patients of 5 years or greater is a little bit different than patients of 0 to 4 years. SABA is still taken, short-acting beta agonist, for intermittent asthma every 4 to 6 hours as needed. To gain more rapid control, the inhaled corticosteroid is added, and for steps 2 to 3 for mild persistent asthma, a low-dose inhaled corticosteroid is used, or a adjunctive therapy can be added with the low-dose inhaled corticosteroid. For steps 3 to 4, medium-dose inhaled corticosteroid is added. And then for severe persistent asthma, step 5 and 6, a high-dose inhaled corticosteroid and LABA long-acting beta agonist is used. So I included the chart again for the treatment and management of asthma, which makes it a little bit easier to see. So for intermittent asthma, you can see the SABA PRN is preferred. And then for persistent asthma, the inhaled corticosteroid is used along with LABA. Based on which step. So for step 2, the inhaled corticosteroid is used, but you can also have an alternative. For step 3, the medium dose is used for moderate persistent asthma, or the option is to have a low dose inhaled corticosteroid with a long-acting beta agonist. For step 4, which is moderate persistent, you can have the medium dose inhaled corticosteroid and the LABA. And then for step 5 and 6, which usually deals with severe persistent asthma, there's a high-dose inhaled corticosteroid plus LABA. And you can also have an oral medication and medication for allergies. So there could be an oral corticosteroid used as mentioned in step 6. So this slide just includes a summary of some of the challenges of understanding asthma's diagnosis and treatment. So I found this topic to be challenging because of the complicated diagnosis. So there's several things to consider when diagnosing a patient with asthma, including their history, a physical exam, and then their spirometry results, and then also management of asthma using the peak flow meter. And then the 4 stages of asthma, including the intermittent and then mild, moderate, severe persistent asthma. And then having the different treatments provided for the patient based on the stage and the severity of symptoms. So there's a lot of information to remember, but this presentation definitely helped me understand the disease and diagnosis and treatment better. And this is the references slide.